Hello friends, in this brief video today, I will be discussing the details of operation room setup, port positioning and how to get retroperitoneal access in retroperitoneoscopic pyeloplasty. This is the template OR setup and patient positioning of a right-sided retroperitoneoscopic pyeloplasty. Now, for a right-sided retroperitoneoscopic pyeloplasty, the child will be positioned in a full lateral position with right-sided up and a roll kept below the opposite left flank so that the right flank opens up and becomes more prominent. The anesthetist will be standing on the head end of the patient and the surgeon, assisting surgeon and the scrub nurse will be on the back of the patient while the monitor will be facing in front of the patient. For port positioning in a retroperitoneoscopic pyeloplasty, it is a useful exercise to mark the anatomical landmarks along with the ports. Here, as you can see, that we have marked the 12th rib and the iliac crest. The 10 mm camera port is stationed 1 cm below the tip of the 12th rib and the two 3 mm working ports are stationed at the costovertebral angle and above the iliac crest respectively. One has to be very careful while inserting the port above the iliac crest because here the peritoneum can be adherent. So what I do is I insert this port at the last so that we can make some space adjustments with the left working port while we are inserting this working port. Now the biggest question is how to access the retroperitoneal space. The best reference article which you can get is from the El Gunemi group from France, which was published in European Urology in 2013. So to access the retroperitoneal space, one has to have two principles in mind. A, that we should not open the peritoneum while getting access into the retroperitoneum, and B, the access should be in such a way that when we start the insufflation, the pressure should push up the kidney and the pelvis should hang down. For both these principles, you need to get an access into the retroperitoneal space as posterior as possible, and at the same time one must also be careful that he or she doesn't enter the paraspinal or the quadratus lumborum muscles. As you can see, the red arrow depicts the access into the retroperitoneum, which is posterior enough and the insufflation will push the kidney up. Here the surgeon has entered his scope directly into the Gerota's fascia by opening the Gerota's fascia. Now what I do differently is I get an access into the retroperitoneal space and use a balloon dissector to create working space for entering the two working ports. Once all the three ports are inserted, then I open the Gerota's fascia. Here we can see the access into the retroperitoneal space by the open technique, and one can easily identify the Gerota's fascia with its yellow color lying below in this wound. At this point, we enter the balloon dissector and create a working space by the Gore balloon technique. This is the first view when we enter the camera after the Gore balloon technique, and we can identify the good working space that has been created by the balloon dissector. All the port sites have good cosmetic outcomes. However, I would like to advise the youngsters to have 1.8 to 2 cm long incision for camera port insertion in the beginning. Otherwise, you will struggle in the most crucial step of retroperitoneoscopic pyeloplasty. With time and experience, your incision size will automatically decrease to 1.5 to 1.6 cm sized incision.